Hello and welcome to this week's episode of Medisodes, where we'll be taking a look at the different healthcare systems across the world. This is going to be a two-episode series where we cover the different healthcare systems in the first episode. In the next episode, we'll be discussing the advantages of different healthcare systems and a few examples of how some countries have very different and unique approaches to healthcare. The table on the slide shows the different healthcare systems that we will be covering. But first, on to Anupam, who will be talking about the national insurance model.
So the national insurance model probably has its most famous example in the UK, where it's also known as the Beveridge model. This model was first established by William Beveridge in the United Kingdom in 1948, after his Beveridge Report in 1942, a report that aimed to reform healthcare in the United Kingdom following World War II. So how does it work? Well, the Beveridge model, or the NHS right now, is financed through general taxation, with a single-payer government. This removes all competition in the market, and almost all healthcare in the UK is managed directly by the government via the NHS. This means they have complete control of what in-network providers can do and what they can charge for their healthcare, and also has control over what treatments are offered and who gets those treatments. This also means that all citizens get a consistent level of care, no matter where they are. And the range of services they provide will be free at the point of need. That means no one pays for their treatments as and when they need them. Instead, they pay for their treatments via taxation. The NHS is usually described as being these three things: comprehensive, universal and free, and from cradle to grave. The first means that they offer treatments for every single type of illness or disease that a citizen in the United Kingdom may get. The second, universal and free, means that it is available to everyone in the UK who's a citizen, everywhere and for no price whatsoever at the point of delivery. And from cradle to grave is a catchphrase very closely associated with the NHS, referring to how they'll treat UK citizens for the entirety of their lifetime. They'll deliver them when they're a baby, and they'll treat them when they die as well. A quote from the founder of the NHS, Aneurin Bevan, is that no society can legitimately call itself civilized if a sick person is denied aid because of lack of means. This was the sort of founding principle behind the NHS, that all citizens in the UK had a right to healthcare, even if they didn't have the means to access it at the time, and that accessing it would be made available through the NHS. And so anyone can access the NHS. This also means there's very little out-of-pocket payments in the UK. Instead, around 18% of a citizen's income tax goes towards healthcare. This is via the King's Fund, which is the primary method through which money goes towards the NHS. It goes from the Treasury in the King's Fund to the Department of Health and Social Care. This money is then divided up between the different NHS regions, such as NHS England, who then passes on the money to clinical commissioning groups, who are responsible for different areas of the country. This money finally ends up at the provider of services. The NHS is actually one of the largest employers in the world, employing 1.3 million people, and is the world's largest employer of highly skilled professionals. However, in terms of manpower, they are the 8th largest in the world, behind things such as the US Department of Defense and McDonald's. In the UK, the NHS is a very popular thing and is often cited as one of the reasons British people are proud to be British. A quote from former Tory MP Nigel Lawson says that the NHS is the closest thing that English people have to a religion. However, in the UK, there is a growing presence of private healthcare. Out-of-pocket payments averaged around $630 per person in 2017, although this is very disproportionate considering the number of people who are actually using private healthcare. The private sector is growing, thanks to employers offering healthcare benefits and much more. And it's also led to 50% of specialists working in private hospitals. So what are the advantages of having this national insurance system? Well, first off, it's quite cheap. The UK spends less than the OECD average on their healthcare, thanks to the NHS system. And it also means that people aren't deterred from seeking treatment. It opens up treatment to almost everyone who needs it, and it incentivizes people a lot more to get involved in national health schemes such as vaccinations. Furthermore, the NHS as an employer means that the UK economy has strengthened quite a lot, and a lot of people cite working for the NHS as being a dream come true or a great thing to do. Finally, it allows a national focus on prevention rather than treatment. Thanks to having a national organisation like the NHS, prevention schemes can be rolled out across the country equally in all parts. However, there are disadvantages to this system. One is that demand always outstrips supply. Even within the first year, the NHS overblew its budget by a large margin. And even since then, the NHS is always spending more than they can actually afford, and the government struggles to finance all the healthcare that it requires. This also means that doctors often get paid quite low wages compared to their counterparts in private medicine. The NHS simply just can't afford to keep paying everyone competitive rates. It also means there's quite a lot of health tourism in the UK. People come to the UK and, by getting UK citizenship through marriage or other means, they use the NHS's services, or they use the NHS's services via emergency situations. And this is estimated to cost the NHS between 100 million to £1 billion every year. It's also funded by the taxpayer, which is a good thing as it means they can collect large sums of revenue, but it's also a bad thing as it means they're answerable to the British public for whatever they do. And there are many times where scandals within the NHS has caused uproar within the general population. It also ties them quite closely to politics, thanks to this, as whatever government's in charge determines how much money they get spent on the NHS. And this in turn can cause a lot of issues in terms of what areas actually get funding. For reference, in 1950 the NHS spent an estimated £460 million, but by 2020 it's likely to spend over 340 times as much, around £158.4 billion on healthcare. After adjusting for inflation, this is still 10 times as much as it spent 70 years ago. Why is this? Well, the NHS has more employees, as it's now covering almost every part of the UK, and all its employees working in the GPs, hospitals, clinics, and more have to be paid for. Furthermore, the UK has a growing and ageing population, and with an ageing population comes more and more health difficulties and conditions that need to be tackled. Finally, the UK has seen economic growth, which has meant that changes in how the NHS is funded, as well as the priorities of the current governments in public spending, have shifted, meaning that the NHS doesn't always get as much money as they need. So how's the NHS structured? Well, NHS as a national organisation is broken up into departments. For example, NHS England, which was created in 2013, is responsible for commissioning, planning, and buying of major NHS services within England, and sets a lot of their NHS strategy, and acts as a sort of headquarters for the England portion of the NHS. Similar organisations are set up within Scotland, Wales, and Northern Ireland. There's also sub-departments which are not linked to regions, such as NHS Improvement. This oversees specific NHS trusts and local community centres, and ensures that money is spent efficiently, and is basically a sort of overview organisation that is trying to make sure the NHS is always improving. On another level, there are the clinical commissioning groups that I mentioned earlier. There are around 200 of these within the NHS, and their aim is to identify local health needs and plan care for people in their local area. However, the most notable of these clinical commissioning groups isn't a local area one, but is instead the CQC, or Care Quality Commission, which inspect the quality of care provided with the NHS. These are sort of a self-appointed ombudsman who make sure that the NHS is providing the correct type of healthcare and at the same rate for everyone. All in all, the NHS system is one that has survived in the UK for 70 years and has grown increasingly popular. It's also been copied in other countries, such as New Zealand, Spain, Italy, and Greece, and is shown to be quite a popular system in terms of healthcare. Now I'm going to hand over to Adrian, who's going to talk about how they do it in the United States.
Now we move on to the next type of healthcare system that will be discussed in today's episode. I will be discussing privatized free market healthcare, with the USA as a case study for this healthcare model. In a system of free market healthcare, Prices for healthcare goods and services are set freely by agreement between patients and healthcare systems. The laws of supply and demand are free from any intervention by any external government and price-setting monopoly. In the United States, there is no NHS. If someone gets ill, it is likely that they will have to pay for their treatment. The US government does fund two kinds of health plans, Medicare and Medicaid. They're designed primarily for the elderly, disabled, poor, and young. These are the groups of people who are most likely to need to use the health system. Many have their healthcare paid for by employers, however, and one of the factors that people who look for a job have to consider is the extent to which the employer will cover their health. However, in 2007, almost 46 million in the USA didn't have health insurance, and this figure is rising as many continue to lose their jobs. 62% of bankruptcies in the US are claimed to have been caused by health costs. Hospitals don't refrain from giving people healthcare if they need it, even if the costs are high and the people don't have the ability to pay for it, which means that the patient will often struggle with healthcare costs up to decades after their treatment. Often, people who don't have health insurance in the USA will neglect their health and avoid seeing a doctor because of the steep health implications, which obviously isn't good and should be discouraged. Health insurance does not have to be paid by an employer, and a person can take independent health insurance paid directly to the company. Health insurance isn't as common as it should be, however, with many people deciding that it is too unlikely that they will need substantial healthcare, and so not taking health insurance to try and save some money. Financially, the US spends more on healthcare services than any other nation. These expenditures are financed by a complex mixture of public payers, as well as public insurance and individual payments, due to there being no single national healthcare system. As I've mentioned before, instead of the government providing healthcare to the public, they rely on employers to provide this healthcare insurance to employees. The variance in the benefits provided by the insurance means that healthcare isn't one consistent standard across the US, unlike where we have a single NHS here that operates at single standards across the country. People who can afford to pay more or work in more high-profile or high-paying jobs have access to the best quality of healthcare and are covered for more injuries and health issues. Some people have both employer and private health insurance, while some have neither. For those who don't have insurance, health costs are often paid off through long-standing loans or charitable donations in extreme cases of very high costs. Costs for healthcare can rise up to millions of pounds for a single patient, and this is often way beyond their reach to pay within their lifetime, so debt will be passed on to future generations. Most hospitals are owned by private non-profit organizations, while the rest are government-run or for-profit corporations. Physicians are mainly employed in the sector and are paid on a fee-for-service basis most of the time, in contrast to a capitation basis. In the fee-for-service model of paying doctors, they are paid because of the services that they provide and the procedures that they perform, whereas in the capitation model, they are paid based on the number of patients that they see. Currently, about 40% of physicians in the US are in solo practice, though the number of group practices is currently increasing. There are more than 570,000 physicians in active practice since 1988, or 2.3 per thousand population. This figure is significantly better than the 7.4 doctors per thousand that we have in the UK, and this represents the increased attractiveness of the profession in the US, given how much more money doctors pay, since there is no national health system and the money is not coming from taxpayers. The figure is so low for the US that a physician's surplus was predicted for the 1990s. And this causes concern because one theory suggests that increased physicians can create demand and thus compound rising health costs. Despite having the highest health expenditures in the world, the US does not perform particularly well in terms of gross health expenditures. As in many countries around the world, particularly the more developed, health outcomes for minority groups are much worse than majority groups, but health insurance availability affects those in minority groups more, which explains this. When discussing a privatized model of healthcare, it is only natural to mention concerns around the NHS being privatised. The involvement of the private sector in the NHS is a hotly contested topic, despite them always having played a role in the NHS before. In the fiscal year 2019 to 2020, NHS commissioners spent £9.7 billion in services delivered by the private sector, which represents 7.2% of the total revenue budget. The spending on primary care services, including GPs, pharmacy, and dental services, are included. Some have estimated that approximately 25% of NHS spending goes in the private sector. Increasing spending on privatised sectors introduces stresses that costs will have to be passed on to patients, since private medical suppliers are generally more expensive. However, as demand is increasing and the regular unprivatised social suppliers are unable to cope, it is to the privatised suppliers that the NHS must turn. And this has been increasing over recent years, and it is yet to be seen to what extent this will affect the NHS and whether it is good in the long run. I now hand over to Shrey, who will be talking about the social insurance model of healthcare.
A system which is kind of a hybrid of the last two you mentioned, social insurance. And I'm going to be using Germany as my example, and it's been described as an all-payer system. And specifically in Germany, they have the Bismarck system. And this is because it's based on the system created by Otto von Bismarck in 1883 in the Health Insurance Act. And it's described as the first social healthcare in the world. Many other European nations, such as France, Belgium, and the Netherlands, also have this system, and it consistently ranks among the most effective and highest ranking system. It can also be described as universal healthcare because everyone is covered in one way or another. So in Germany, health insurance is compulsory. You have to have some sort of health insurance, whether that's public or private. And 90% of Germans choose the statutory healthcare, which is effectively public healthcare system. And they contribute 7.5% of their wages, and the employer matches at another 7.5% of their wages into so-called sickness funds, also known as SHIs, which are statutory health insurance funds. The public system is known as Gesetzliche Krankenversicherung. I apologize for my poor pronunciation. And these are what most Germans use, and it's effectively a tax, but paid to, these are organizationally and financially independent bodies, which, although they have to carry out tasks assigned to the state, the German government tells them what to do, they are independent from the German government. And this is actually quite different from the national insurance model, that the government actually has a limited role in direct delivery of healthcare. And instead, the National Association of SHI Physicians, the National Association of SHI Dentists, the German Hospital Federation, the National Association of SHI Funds form the Federal Joint Committee, which decides what the statutory healthcare insurance covers. And there are 13 voting members. 5 are from SHI funds, 5 are from providers of healthcare, and there are 3 other voters. And the statutory health insurance covers inpatient, outpatient, mental health, and prescription drugs. However, so-called lifestyle drugs are excluded, and there are some costs, I'll come on to. It's also compulsory to get accident insurance, which is usually covered by the employer, and that's for accidents at work and commuting, and that's known as Arbeitsunfallversicherung. Again, apologies for my pronunciation. And also long-term care, known as Pflegeversicherung. And if we look at how much Germany spends on healthcare, it's quite high at 11.5%, one of the highest in Europe, and about 74% of that is publicly funded, and about 57% of it is of that is from SHIs. You can also get private health insurance, but you have to earn over 68,000 euros before you're allowed to opt out of SHI, and that's about 10% of the population. It's also important to know that income above 54,000 euros is exempt from that 7.5% voluntary. From that 7.5% contribution. So that means that in theory, the maximum Germans should have to pay for their health insurance is about 4,000 euros, which is not too bad. Interestingly, the private and the public health insurance uses the same providers. We'll look at hospitals later. Also, luckily, children and dependents are included. They don't have to pay extra, although in SHI they do have to pay extra in PHI. And it's important to note also that the PHI is highly regulated and that mothers don't pay during maternity leave because that would be unfair because they're not earning. Moving on to the principles that underpin this German system, there's the solidarity principle, which means that it guarantees that each insured person receives all treatments that are medically necessary, regardless of income, the insurance premiums paid, or the morbidity risks. There's also benefits in kind, which means treatments are made without upfront payments from the insured. If we look at how care is delivered, there are 35 public universities and 5 private universities that offer medical degrees, and all the public ones are free, and a lot of them are very famous throughout the world. The 5 private ones, fees range between 6,000 euros and 11,500 euros per semester. Looking to primary care and outpatient, GPs work in private practice, so about 56% work in sole practice, 33% in dual practice, and the rest in group practices. Patients have a free choice of GPs. They can choose whichever GP they want. They're not assigned to, and and you don't have to register with a family doctor as you do in the UK. There's also a free choice of specialists, which is nice as well for the patient, and it gives them more autonomy. GPs also don't have a gatekeeping function like they do in the NHS. So in the NHS, you have to go to your GP before you're allowed to see a specialist in a hospital. While in Germany, you can go straight to the specialist. However, there are incentives to go into your GP first in order to make sure that the system is as efficient as possible. And if we look at how the GP practices are paid, they're usually reimbursed by the SHI funds. There are about 109 SHI funds, and each offer slightly different benefits based on what they're negotiated, but they're reimbursed on a fee-for-service basis, and the fees are negotiated between these SHI funds and regional physician associations. And each SHI, the SHIs were originally to do with what people did as a living. So, for example, you'd have the metal workers SHI or the engineers SHI, but now it's much more market-based in that SHIs are allowed to market themselves just based on different benefits that they can give to the consumers. But however, it's important to note that SHIs are not for profit, and they're being described as quasi-government bodies because basically they have to do what the government says. If you look at after-hours care, it's usually organised by these regional associations, and there's also for assistance, there's a national telephone hotline. But physicians are obliged to see people after hours in their practice. However, this varies by region. For example, in Berlin, this is delegated to hospitals, the after-hours care, and then the hospitals will give you a letter to give to your GP. If we look at hospitals now, about half of the beds are public. Another third is private, but not for profit. And then the rest, the remaining sixth is for profit. However, this is rising. And most physicians are salaried, like in most other countries, rather than a fee for service. And if we look at inpatient fees, they're classified by a system called diagnosis-related groups per admission. So that means that different interventions are classified into different groups and given different prices. And for basically a hospital visit is about €10 per day. As I said, it's universal healthcare, but there are these small fees. €10 for 1 day in a hospital, but that's capped at 280 €280 per year. So that covers you're covered after 28 days in hospital, which is good if you have like a chronic condition that needs to be in hospital. However, and also senior doctors can treat private health insurance people on a fee for service basis. However, there are some things that the German system doesn't cover. For example, dental cover is not really covered as well, and many people have both PHI and SHI at the same time. Usually they get private health insurance for things that the statutory one doesn't cover. But consistently, Germany has been ranked as one of the best healthcare systems in the world. There are some other problems with the fact that with 109 different funds, it's very inefficient, which is very un-German. Perhaps that's the cost you have to pay for the added competition and the fact that most Germans are extremely happy with their healthcare system. And also, unlike the NHS, Germany has been found to have very low wait times, which is a key problem that the NHS has. And perhaps the UK could learn a bit from Germany. So we've mostly been talking about how healthcare is delivered in developed nations such as the UK, US, and Germany. So now Shri is going to look at how other countries that might not be as wealthy deliver healthcare.
Looking at the types of healthcare systems in developing countries, they are usually ones that have been previously discussed. For example, Bhutan has been offering free universal healthcare for all its citizens since the 1970s, whereas Malaysia's healthcare system consists of both a government-based universal healthcare system and a coexisting private healthcare system. It is also important to note that war and conflict in many developing countries has weakened the healthcare systems of many, leading to them not having a proper structure in their healthcare system. Instead of looking at the types of healthcare systems in developing countries, let us look at the healthcare accessibility and quality in developing countries. It's no secret that healthcare in developing countries is inadequate. Inhabitants in these countries suffer from unclean water, poor sanitation conditions, and a high risk of contracting infectious and severe diseases. In the 1970s, the World Health Organization set a goal to have universal healthcare across the globe by the year 2000. In 2017, that goal is nowhere near achieved. Much of this disparity centers on health inequalities between and within countries, especially in those less developed. Low-income countries not only suffer from a lack of technology and education, but also lack in the number of skilled professionals working in communities, whereas the result is people dying from treatable diseases like diarrhea. Another problem is that little research and development is conducted on diseases that affect such areas. Most global research spending on healthcare goes towards the prevention and curing of diseases suffered in the developed world, leaving little behind for developing countries. Looking at the inequality in access of healthcare in developing countries, there are wide gaps in the availability of services in sub-Saharan Africa and Southern Asia. In other regions, basic healthcare services such as family planning and infant immunization are becoming more available, but lack of financial protection means increasing financial stress for families as they pay for these services out of their own pockets. This is even a challenge in more affluent regions such as Eastern Asia and Latin America, as well as Europe, where a growing number of people are spending at least 10% of their household budgets on out-of-pocket healthcare expenses. Inequalities in health services are seen not just between but also within countries. National averages can mask low levels of health services in disadvantaged population groups. For example, only 17% of mothers and children in the poorest fifth of households in low and lower middle income countries receive at least 6 of 7 basic maternal and child health interventions, compared to 74% for the wealthiest fifth of households. This being said, there has been a recent shift towards bringing healthcare to developing countries. First, the United Nations acknowledged the health disparities and the lack of healthcare systems. To resolve these disparities, the Millennium Development Goals were created, and with the Sustainable Development Goals following close behind. Each set of goals attempts to improve healthcare in less developed countries using the resources available to the world's most developed nations. Now let's look at two of the different ways in which healthcare can be improved in developing countries. The first way involves increasing benefits for the poor. The poor are the most vulnerable when it comes to health risks. For people who don't have the means to afford healthcare services, governments must step in the way to provide this for them. A family who still have to think about what they have to eat for their next meal cannot set aside extra money for healthcare services. The tendency is they will put off going to the doctor even if they feel something's wrong with their body. The main reasons are that they lack the financial capacity to do so. By increasing the health benefits of the poor, governments can change this mentality. Once they know that a healthcare service is available for them, they can turn to these services so that they can take care of their health. The second way of improving healthcare in developing countries involves promoting primary and essential healthcare. A way to improve health in developing countries involves governments providing cost-effective health packages for everyone. An example of this would be Ethiopia and Malawi, where governments have focused on achieving universal vaccine coverage, developing cleaner water supplies, and creating better sanitation practices. On a broader scale, as part of the Sustainable Development Goals, the UN has agreed to pursue universal healthcare by 2030. The initiative to create universal healthcare includes access to quality essential healthcare services and access to safe, effective, quality, and affordable and also essential medicines and vaccines for everyone. By making availability universal, resources can be directed towards primary level facilities of care that strengthen the overall treatments that people will be receiving. So hopefully this has given you a brief insight into the accessibility and quality of healthcare systems in the developing countries. Thank you for listening to this week's episode of Medisodes. In the next episode, we will be having a discussion about the different healthcare systems, as well as looking at some countries that take a different and unique approach to healthcare. So tune in next week to listen to this interesting discussion. So don't forget to like, share and subscribe to Medisodes for more weekly episodes. Thank you.